Good evening. It's 8 p.m. UK time. We can start our live event. I'm your host, Dorothy, and welcome to Egg Donation Friends webinar. Today's topic is IVF with donor eggs, low ovarian reserve, patient case study. And today's presenter is Dr. Laura Villar Torres from Mexico. The doctor's presentation will last about 25-30 minutes, and then the Q&A session will follow. I just want to confirm with everyone, if you can hear me well, can you type in the chat section, please? Yes, thank you. Okay. Fantastic. If you want to ask a question for Dr. Laura, please type it in the chat section during the presentation or after the presentation. Dr. Laura will answer your questions after she will talk about the patient case study she has chosen for us today. The webinar is being recorded, and you will be able to view the recording on our website and also on our YouTube channel. The recording will appear tomorrow during the day, so stay tuned. We will also publish a complete transcript with all the questions and answers. Dr. Laura, can you hear me? Can we start?
Yes.
Fantastic. Okay. I will ask you to speak up a little bit so we can hear you better. I think louder is always better, or closer to the microphone, and that will be great.
Okay, good.
Okay.
Is that okay?
I think it's fine. Yes, I think if we get feedback from the participants. Can you hear
Okay.
Dr. Laura? Yes, I think just waiting for feedback from participants. Yes, I think yes. Okay, everyone can hear you well. Fantastic. Okay, the floor is yours. Let's start.
Okay, good evening. First of all, I would like to thank Egg Donation Friends and Dorothy Wallace for the invitation and for the opportunity to talk about our patient experience here in the Reproduction Unit in Mexico City. As you know, I am going to talk about IVF with donor eggs, low ovarian reserve, and age with a patient case study. So let's start. Here it is the patient information. A 44-year-old editor married to a 45-year-old teacher had already gone through 3 IVF cycles without success. The first cycle, the ovarian stimulation was done with high dose of gonadotropins. They got 3 oocytes, 2 mature, 1 fertilized, and 1 embryo with bad quality, so there was no embryo transfer in that cycle. The second cycle, it was done with high dose of gonadotropins too, but they decided to add androgens. That cycle was canceled because the ovaries of the patient didn't respond to the stimulation. The third cycle, the ovarian stimulation was done with growth hormone, and they got 3 oocytes, 3 mature, 2 fertilized, and 1 embryo arrested in day 2. It means that the embryo stopped its development. She has been smoking 5 to 8 cigarettes a day for the last 10 years. And there are some laboratory results. FSH, 14 milli-international units per milliliter. LH, 11 milli-international units per milliliter. Estradiol, 80 picograms per milliliter. AMH, or anti-Mullerian hormone, 0.8 nanograms per milliliter. Her antral follicle count was in 3 follicles, and she had an hysteroscopy and endovaginal ultrasound. Both of them were normal. Above him, he had 2 spermatobioscopies, both of them with oligoastinospermia. With this information, they came with us. We analyzed their case and decided to go for egg donation. In the oocyte retrieval, we got 70 oocytes, 13 mature oocytes, 10 fertilized, and 8 embryos, 5 with good quality. The donor's age was 25 years old. At the same time, we made the endometrial preparation for the patient and for the fresh embryo transfer. So we transferred 2 A-quality embryos in day 5. At this moment, she has a 34-week single pregnancy. So let's analyze some important factors of the patient. Here is the patient analysis. First of all, her age. She is 44 years old. Her FS is in 14 milli-international units per milliliter. Her AMH or anti-Mullerian hormone is 0.8 nanogram milliliter. Her antral follicle count was 3 follicles, and she already had 3 failed IVF cycles. She also smokes up to 8 cigarettes a day. So with this information, can we ask us, does she have a low ovarian reserve, or is she a low responder, or maybe both? So it has long been known that with increasing chronological age, female fecundity decreases. But why? Female reproductive aging is a process that follows the generally accepted theory that over time, oocytes decrease in quantity and quality and do not regenerate. As we can see in this graphic, in the x-axis we have the age of a woman, and in the y-axis we have the relative hazard of a first pregnancy. And it represents this graphic the fecundity per cycle according to female age. It is the mean rate for women aged 20 to 30. It was scaled as 1, as we can see here. So for a woman aged 33 years, the relative rate of 0.75 indicates that she has in each cycle 75% of the chance of a woman aged 20 to 30 of getting pregnant. But what about a woman of 35 years old? She has a 30% of the chance of a woman aged 20 to 30 years. And a woman of 40 years, for example, she has only 50% of the chance of a woman aged 20 to 30 of getting pregnant. But I guess you're still wondering why female fecundity decreases with age. Each woman receives an endowment of oocytes during the fetal development. At the 4 months of fetal life, the ovaries contain some 6 to 7 million oocytes, as we can see. Due to a rapid loss of the great majority of the primordial follicles via apoptosis in the second half of fetal life, at birth, only 1 to 2 million primordial follicles remain, as we can see here. After birth, this high rate of follicle loss slows down somewhat, so that at menarche, at least 300,000 to 400,000 primordial follicles remain. During the reproductive years, the continued and gradually accelerated decline will cause numbers to have dropped. So by the mid-30s, it is 30,000 and below 1,000 at time of menopause. These numbers just represent averages. The actual number of a woman's sex supply will vary from woman to woman. Although this reproductive decline occurs with age, there is significant variation in fertility among women of similar age, which highlights the unpredictability and individuality of the reproductive aging process. Factors such as genetics, as Turner syndrome or FMR mutations, lifestyle like smoking, environment, and medical issues like endometriosis, ovarian surgery, chemotherapy, radiation, uterine embolization, autoimmune disorders, galactosemia, FSH receptor polymorphisms, and idiopathic, all can influence the quantity and quality of a woman's oocytes. Along with the decrease in follicle number, oocyte quality also diminished. The loss of oocyte quality is believed to be due to an increase in meiotic non-disjunction, resulting in an increasing rate of aneuploidy in the early embryo at higher female ages. So in this graphic, we can see in the x-axis, we have the age in years, and in the y-axis, we have the number of follicles. As the age increases, the number of follicles decreases. Between 20 to 30 age, it is the optimal fertility period. Then fertility starts to drop until it's end at the age of 50. Otherwise, as the age increases, the quality of the oocytes increases too. But what is the ovarian reserve? The ovarian reserve, it may be defined as the number and quality of the remaining follicles and oocytes in both the ovaries at a given age. And how ovarian reserve is measured, and when is a low ovarian reserve considered? Well, we have some methods like clinical, biochemical, ultrasound imaging, and dynamic tests. For example, clinical, we have the age and menstrual cycle characteristics, but they are not precise. Biochemical, we have the FSH, the estradiol, the AMH, and the inhibit B. By ultrasound imaging, we have the antral follicle count and the ovarian volume and blood flow. And by dynamic, I mean the clomiphene citrate challenge test, the exogenous FSH ovarian response test, and the gonadotrophin agonist stimulation test. Because no single assessment of ovarian reserve has 100 sensitivity and specificity, tests often are combined in an attempt to improve the prediction of poor outcomes. Anti-Mullerian hormone and antral follicle count are the most accurate predictors. FSH is an indirect marker for ovarian reserve. It is produced by the hypophysis. Levels greater than 10 to 20 milli-international units per milliliter are associated with diminished ovarian reserve and poor response to ovarian stimulation. The test is not predictive of failure to conceive. Estradiol is an elevated value greater than 60 to 80 picograms per milliliter in the early follicular phase can indicate reproductive aging and hasten oocyte development. Basal estradiol has low predictive accuracy for poor ovarian response and failure to conceive. What about anti-Mullerian hormone? Well, it is a glycoprotein hormone that is produced by the granulosa cells of primary, preantral, and antral follicles from 2 to 6 millimeters in diameter. As the number of ovarian follicles decrease with age, a concomitant decrease in anti-Mullerian hormone levels occurs, which reflects this age-related oocyte depletion. One limitation of anti-Mullerian hormone level testing is the variability of results between the available assays. About ultrasound evaluation of ovarian reserve, it is a subjective measure, but we have the central follicle count, so it records the number of visible ovarian follicles from 2 to 10 millimeters mean diameter that are observed during transvaginal ultrasonography in the early follicular phase. The number of antral follicles correlates with the quantity of remaining follicles and with the ovarian response during controlled ovarian stimulation. And low antral follicle count is considered 3 to 6 total antral follicles. But it does not reliably predict failure to conceive. So what happens if you have diminished ovarian reserve? And should a woman with low ovarian reserve must have symptoms? It is important to recognize that a poor result from ovarian reserve testing does not signify an absolute inability to conceive and should not be the sole criteria considered to limit or deny access to infertility treatment. At this time, ovarian reserve testing results cannot be extrapolated to predict the likelihood of spontaneous conception. And compared with women of similar age, commonly both have regular menses but a reduced quantity of ovarian follicles, and thus may have a limited response to ovarian stimulation with fertility medications. higher cycle cancellation rates, and lower pregnancy rates during in vitro fertilization. And which is the best reproductive treatment if you have low ovarian reserve? Well, it depends on some factors, for example, the age and the relative response to fertility medications. If a younger women less than 37 years produce 2 or 3 good quality embryos at the end of stimulation, they have a reasonable potential to achieve a pregnancy after IVF. The chance of getting pregnant in women older than 40 with few embryos is much lower. If we compare effects of low ovarian reserve and age, it is clear that age has more negative effect on reproduction. Age is associated with low egg quality, while ovarian reserve mainly is big for the number of oocytes in the ovary. Because the response to fertility medication is difficult to judge just based on ovarian reserve markers, most women should be encouraged to try ovarian stimulation once at least, and most women should not be denied treatment based on the notion of low ovarian reserve. Various treatment regimens have been designed to manage the patients with diminished ovarian reserve and include, for example, high dose of gonadotrophins, natural and modified natural cycles, estrogen priming, supplementation with LH, luteal antagonist, and letrozole treatment, and the use of adjuncts like androgens, growth hormone, melatonin, and aspirin. We have the oocyte donation and assisted hatching. Just to remember that woman's age is the single most important indicator of fertility potential. Woman's fertility decreases further after age 35. And well, we can see in this graphic, in the x-axis, we have the age, and in the y-axis, we have the percent. And it represents the pregnancy and the live birth rates for assisted reproductive technology cycles using fresh, non-donor eggs or embryos but female age. For example, a patient who is 25 years old, her pregnancy rate is 37% and her live birth is 33%. But what about women of 45 years old? Her pregnancy rate is only 5% and her live birth rate is only 2%. So among women in their 20s, percentages of ART cycles using fresh non-donor eggs or embryos that resulted in pregnancy were relatively stable. However, percentages declined among women in their 30s onward. A woman's age is the most important factor for having a live birth when her own eggs are used. In this graphic, we have the live birth rates for ART age. So we can see in the x-axis the age, and the y-axis we have the percent. So the green line represents the live birth rate of the non-donor eggs. The line starts to drop at the age of 33, with almost 0% at 45. Unlike the blue line, in which the live birth rate is maintained at an average percentage of 60% from 25 years to 48 years old. So the percentage of ART cycles in which a woman uses her own eggs decline with age, while the percentage of ART cycles using a donor egg increase with age. Percentages drop steadily with each 1 year increase in age. So, which are my chances of pregnancy with low ovarian reserve? It will depend on many factors like the causes of diminished ovarian reserve, which may mean that each patient requires individualized counseling and motivation. At the end, we believe a thorough patient counseling and protocol personalization are the keys to optimize reproductive outcomes in such patients. So, as conclusions, I can say that women born with their entire lifetime's egg supply, that decreasing ovarian reserve is inevitably with increasing age, that ovarian reserve is a measure of how well the ovaries are still functioning at a certain point in time, that a good test of ovarian reserve should be predictive of conception and should indicate how long current levels of ovarian activity can be maintained before ovarian aging sets in, that various treatment regimens have been designed to manage the patients with diminished ovarian reserve. Oocyte and embryo donation is an established standard of practice for the treatment of age-related infertility and is associated with big rates of pregnancy success. And the oocyte donation reverses the age-related decline in implantation and birth rates of women in their 40s and 50s. It is important to understand that IVF is an art science blend and not all practitioners agree on the same strategies. At the end, we believe that through patient counseling and protocol personalization are the keys to optimize reproductive outcomes in such patients. So, thank you very much.
Thank you very much for the presentation. So now it's time for questions and answers from our participants. We have a couple of questions already. Okay, let's start. The first question, how many times it is allowed to stimulate an egg donor in Mexico?
It depends, but okay, we usually stimulate no more than 3 times per donor. It depends on the results of the donor, how many oocytes get at the end, but no more than 3 times.
3 times, is it correct? I'm sorry, the sound is a bit off. I'm not sure
Okay.
what happened. Okay, it's better now. Thank you very much. Did you say 3 times? I was not sure.
No more than 3 times per donor.
Fantastic.
But it depends on how many oocytes do we obtain at the end.
Okay, thank you. And next question. I am 38 years old. FAC is 11. AMH was about 8. I don't know the unit. I had 2 failed IVF with my own eggs. Shall I move to donor eggs, or should I try 1 or 2 more IVFs with my own eggs?
Well, it is important to know all the context of your case. I think you could have better results with maybe with a donor cell. But I would like to know more about your case with specific information. So if you could send us or leave us your email so we can be in contact with you and talk about more about your case.
Okay, I think it won't be a problem to contact the patient directly. Okay, this is a very specific case. Let's take another question. How early can the low ovarian reserve be discovered?
How early can I don't understand the question.
Yes, I think Alinda is asking. Okay.
At what age or something like that?
I think so. I'm not really sure either. Maybe the question is how early can the low ovarian reserve appear? At what age, I think. Is that the question, Olinda? Okay, maybe let's wait for clarification, and we will
Okay.
come back to that question. Okay, maybe it's not very clear.
Okay.
Okay. Can the AMH test be done without the approval of the patient?
No, because it is a blood test, so we need to take off a blood sample of the patient, so we can do that.
Thank you. Next question. What's the percentage of mistake or error in conducting the test?
What kind of test? The AMH or what
Yes, I
kind of
think
test?
these are the
Because we
questions
have
from the same
many.
patient. Yeah, AMH, I guess.
Okay, it depends because the laboratory, it is important to know that it is a I don't know how to say it, certificate laboratory. So it is important to know that it is an error. How to say it? It has an important, just like 5% of mistake. So it is important to use not only the blood test, the AMH, so we can make an account of the follicles to correlate the results of the AMH. So we can have two tests to improve the answer or the results.
Okay, thank you. Okay, there are a few questions from the same patient, so there's another one. Regarding the AMH, FSH, and other required tests, it is noticed that labs have different requirements prior to conducting the test. Which one is true?
Different requirements like what?
I suspect these might be requirements like tests to be
That
done
it is
on a
in
certain time of the
day of
month.
the cycle. Yeah.
Yes.
Okay. The AMH we can take the sample in every time. It doesn't depend of the day of the cycle, but the FSH, it is important to take it in the maximum the 5 day of the cycle of the patient. But it is important to have in that time. But the AMH, it doesn't matter. We can take it any time.
Thank you. Next question. How can one verify the clinic and the doctor experience in the field? How can this be done?
In Mexico?
I believe you're the best person to tell us about Mexico, so I think we'll be happy to hear how we can verify doctor's experience in Mexico.
Because we need to have a certificate, so a number of certificate that allow us to work with this kind of cases. So it's important to know that the doctor have this certificate in her place or in the laboratory or the clinic.
Okay, so this is the second part of the question from the same patient. She meant a certified and accredited lab. So do IVF labs have certificates or accreditation? How does it work?
Because we can ask directly the laboratory. They must have a proof, a written proof that they are certificate. It is like how do you say a certificate? The laboratory, so you can go to the laboratory and ask for them for it.
Okay, thank you. Okay. Next question. For those who don't have the IVF in their countries, What are your recommendations on finding the right clinic and medical team?
Okay, you can go with your gynecology. I think he's the specialist that can help you to make some tests, and maybe he can um, give you some advice about the best treatment for you. But obviously you can search some clinics in other countries. In the web we have each clinic have the best results, or yeah, the results. For example, the pregnancy rate, or the pregnancy rate of egg donation, or the pregnancy rate in insemination. And it is important to know that. So many of the Mexican clinics have this data in her web.
Yes, thank you.
Sorry.
I believe success rates are very important for patients, customer service as well. And Alinda, I think you are in the right place. We can put you in touch with our coordinators, Egg Donation Friends coordinators, and they can help you to find the best clinic for your needs. Okay, let's move on to another question. Question from Allison. I'm 42. I have had 8 cycles of IVF were with donor eggs. All these failed. 2 were chemical pregnancies. Could it still work if I try
Well,
again
it
with
is
donor
a
eggs?
very interesting case. Yeah, it could work. If I I think you could again, but we need to know more about you, because we need to know if there is something that in the other IVF cycles are were missing to improve your results.
Yeah, I suggest that Dr. Laura, you can
No?
get in touch with Alison after the webinar and talk about her case. Okay.
Hello.
Can you hear us? Hello, can you hear me? I think we have
I can hear you.
Oh, okay, fantastic. Okay, ready for the next question? Um, what's the age limit for IVF for women in Mexico?
Hello.
Can you hear me? I can hear you.
Dorothy?
Okay, yes, I'm here. Participants can hear me. Can you hear Dr. Laura as well? I can hear her perfectly. I think she cannot hear me. Dr. Laura, are you
Hello.
with us? Yes, we can hear you. Okay, I apologize for these problems. Let me contact Dr. Laura via the chat.
Hello.
Hello, Dr. Laura. Hello, Dr. Laura, can you hear us? Hello? I apologize for the problems. Let me contact the doctor on the phone, and I'll be back in a second. I will try to resolve it as fast as I can.
Hello.
Hello, can you hear me?
What is the age limit for IVF for women? We recommend no more than 45 years old. It depends because you can use donor eggs, but IVF with own eggs no more than 40 maybe.
Thank you very much. And next question. Do you recommend high or low stimulation for a woman with low ovarian reserve? I'm 44 and normally 2 oocytes.
We usually use a high stimulation, but there are many kinds of protocols, but we usually use high dose of gonadotropin, for example, with adjuvants like growth hormone or androgens or other.
Thank you. Next question. My name is Joy and I'm 46. Can I use donor egg?
Yes, Joy, you can use a donor egg. It will be a good results for you.
Dr. Laura, can you hear me? Maybe it's better you read the questions. I'm not sure if you can hear me. Otherwise, I won't read the questions. Let's wait for the doctor to answer.
The concentration is okay. The motility A plus B, it's okay. The morphology and the fragmentation of DNA is not okay. So it could affect the conception. Yes, it could affect it. But we have other techniques like MAX or another techniques that we can improve to have just the better sperm for you. So
very much. Next question. Okay, I'm getting feedback. You cannot hear the doctor. Okay,
I can
this is
understand
very
the question.
strange.
Are you asking how to know if you are ovulating, or I think, okay, we have some clinic test, or the way you can know that you are ovulated is because the mucus of the cervix, it is more hyaline, and because you can have it depends, but we can follow your menstrual cycle, and we can have some ultrasound test to see the follicle growing up, or liquid in the cavity. But you need to go to your gynecologist.
Okay, let's move on to the next question. I think we have used most of the questions. Let me check if there are any new questions left out. Yes, we have 2 more questions.
Do you?
Oh, I think this question we've already answered.
We recommend high dose of gonadotropins or high dose stimulation with low ovarian reserve. There is no specific study that give us success rates. The age is the most important. You have 44, but you can have a baby with you are a good patient for a donor, for use donor eggs, and with a cycle of IVF. So it is not a problem.
Okay, thank you. Maybe again the question about the age limit. We didn't hear the answer.
What is the age limit? The age limit for what? For IVF or for egg donation?
For IVF
Because
and egg
the age
donation,
limit
yes.
of ART treatment or ART is in Mexico or in the reproductive unit is no more than 50 years old. But for a cycle with own eggs with IVF, maybe 42, 43, maybe 45. But after 45 years, we recommend to use egg donation.
Thank you very much. Can a woman with low OR conceive naturally?
Yes, a woman with low ovarian reserve can conceive naturally. Yes, she can, but she have a very low percentage of success rate less than 5%.
Do we have any more questions, please? Yes, we have a question about egg quality. How can we improve egg quality?
It is a good question. How can we improve egg quality? It is very difficult because there is no specific treatment to improve egg quality. The most important fact is the age. You can treat the age, so it's very difficult. But there are some medications or some natural like substances that you can use, but no one can have an excellent results.
Hello, Dr. Laura, can you see the question?
No, the chances are very low. No, the chances are of having a permanent damage to the ovaries is very low, less than 5%.
5%, okay, thank you.
Some complications. The most common is bleeding, but we don't damage the ovaries.
Okay, I think because of the technical problems which happen during live events, it's very difficult for me and the doctor to communicate. And I can see that there are quite a few questions left out. So let's do it this way. Dear all, can you please email me the questions you have? My email is dorothy@ivfmedia.org. Please check the chat, the email is there. Okay. I promise that I will forward each and every email to Dr. Laura, and because of the technical problems, it's not possible today to answer all of them. But I'm sure she will be happy to give you some advice via email. We can try one more question while you note my email address. Okay, let's try one more question. Oh, okay, I'm afraid we lost contact with Dr. Laura. I
Yes,
apologize for
it
that.
is important to know that low ovarian reserve, it is very important to us as reproductive specialists because it will tell us how kind of treatment are we going to use with you. But obviously it could have some clinic how do you say symptoms if you have low ovarian reserve. Not all the women, but you can have irregular menses, or in many cases you can have, or you can start with that kind of irregular menses. But yes, I believe low ovarian reserve, and it is very important for us with IVF.
Let's try one last question.
What is the importance of fish? In what cases?
FSH, I think.
Because it is a proof of the sperm, so we can know that it allows us to know the DNA information. So it is a fluorescence in situ hybridization in sperm. So yeah, it is important. Obviously, for some men who have more than 45 or 50 years and have some spermatogones could be altered. Not because the 3 times could be harmful for the ovarian reserve. Well, obviously we are taking off some reserve of the donor, but it is important to know it depends on how many live birth we can obtain with these outsides. So we can say that, but not because it is something negative for the ovaries. It's because if you have more than 3 babies with the same donor in the same country or something, you can have some problems with the reproductive or the mixes of these information or DNA mix. I don't know if I answered your question.
Maybe the last question for today.
Okay, I was telling you, the fish it is important because it tells us the information about the genetic material of this sperm and the karyotype also. So yes, it is one of the proofs that we usually ask for our patients. What are my recommendations for what? For having a baby, or for those symptoms? Because women uh, with a early menopause can have a baby with egg donation without problem. But if you are asking for how to treat your symptoms, it is important to go with your gynecology. He can help you to treat that.
Okay, due to technical problems, we are forced to end our event a little bit early. But as I mentioned before, all the questions.
The problem with the early menopause and the
Dr.
low
Laura
ovarian
cannot
reserve
hear me.
is you don't have the same response to the ovarian stimulation, even you have few oocytes in your ovaries. So you could have better results with egg donation. that is, I don't know if I answered your question.
Okay. Dear all, please send me the questions to dorothy@ivfmedia.org and Dr. Laura will answer them. We will also publish them in the link I have uploaded before. Okay, I apologize for the technical problems, and I hope you will get the answers from the best source in a very short time. Thank you very much for being with us. Thank you very much for your questions, and I hope to see you during our next live event. Good night.